I'm doing a master's at the moment in sports cardiology, which is discussing a lot of different topics, but the main topic is cardiomyopathies, and I have a particular interest in this subject, hence why I reached out into Cardiomyopathy UK to kind of volunteer my time to speak to groups, particularly around exercise, and I've done quite a few, and this will be about my second or third ARVC group specifically. Excellent. So this is basically then the topic of the slides today, or the purpose is you've been given a certain diagnosis or certain kind of a condition, and you've been told certain restrictions around exercise. When you're told that, depending on the cardiologist you saw, or depending on your nurse, and depending on their knowledge, you may have been given different advice or different awareness. So this purpose of this topic then today is not necessarily to contraindicate what they have said to you, but maybe to create awareness from your side in relation to the condition. So when you are speaking to those health professionals again, you may have more specific questions to ask them that may help you getting back to exercise. Okay, so these are the areas that we're going to be looking at today. Would be physical activity, exercise, sedentary time, and flexibility. Normally, if I'm in a group face-to-face, I will talk about or get a bit of back and forth conversations around this, but because it's online, I'll just talk about it specifically. So in relation to the exercise, or kind of these definitions, physical activity is just basically any movement produced by skeletal muscles that requires expenditure. So basically, from the moment you wake up to the moment you go to sleep, that's all physical activity. It's where you're on your feet moving around, and there's different levels, or sorry, not different levels, but different types of physical activities as discussed here. But generally, what does it feel like? It depends on people's individual fitness levels, but it's generally easy activity. And it's not something that would be strenuous enough to be making you feel out of breath. But yeah, so it's generally lower levels of activity. And the recommendation with this, it can vary from person to person, but these are just the general recommendations at the moment. So we're not talking about ARVC at the moment. These are just for the general public. It's basically as much as you can, ideally, in the sense that you're just reducing sedentary time. Then if we move on to exercise, and this just requires any physical effort to improve your health and fitness, or to make your heart a bit stronger. This is sometimes an area as well where cardiomyopathy patients, and more specifically ARVC patients, will be given stricter recommendations. It can be individualized from person to person, but that's usually the main area that is discussed. And then the 20 to 30 minutes, that's just the general public recommendations, or the general guidelines is 20 to 30 minutes of moderate intensity physical activity or exercise 5 days a week. Moving on to sedentary. This is just links in with physical activity, in the sense that you're just trying to reduce the amount of time you spend sitting down. So every hour or so that you would just get up, have a walk around. In relation to sedentary time as well, just because you're not doing exercise doesn't mean you're not actually gaining benefits from the exercise or from standing. So from standing, there's a lot of research out there that shows you're burning more calories, and it's more challenging to the heart when you're standing. So you're getting kind of physiological benefits from that. So it is beneficial. And then, of course, we've got flexibility. There's different types of flexibility, but this is just helping mobility, and kind of basic forms of this would be like just being able to, say, for example, like wash your hair. There's quite a dynamic range of motion that's involved there, to put your hands behind your head, or even kind of putting on shoes and socks. All of these areas do deteriorate as we get older. And if you have a cardiomyopathy or a heart condition, usually these areas are also neglected, because when people are given diagnosis, at least on the initial stages anyway, they're usually quite anxious or quite nervous about doing any sort of activity. So usually these are the areas then to suffer, or usually to see less improvements on. So these are the areas then, kind of an overview. Sorry, the last one, I should have said, it was strength. And this is generally 2 to 3 days a week of lifting weights, but the weights that you might lift not necessarily involve gym activity. It could be just like kind of household kind of objects like kind of cans of tins of beans, bottles of water, just simple exercises to improve upper and lower body strength. And these can be a combination of kind of body weight exercises. Hopefully it's making sense. I am going through a little bit fast because I am worried about waffling on more than 45 minutes. But if you do have any questions around this, just make a note, and I can discuss at the end with you. So when you are exercising, this is an important scale as well. So this is still sticking with the general guidelines. I'll talk a bit later how we can individualize it. But generally, when you're sitting down, no exertion at all. That's extremely, so that's sitting down. And then above that, as you start walking or as intensity goes up, you get to a somewhat hard where your breathing has increased, but you're not out of breath. Hard, heavy is where your breathing's increased even more and you may be struggling for a conversation. You may not have seen this scale before, but you may have had conversations around this scale in relation to when you ask your cardiologist or your nurse, what level of activity can I engage in? They might have said engage in light activity, or maybe even up towards somewhat hard where your breathing's increased or not out, but you're not out of breath. So this is it can be useful because ultimately having knowledge of this scale helps you to exercise when you're not in kind of when you're on your own, basically, and how to determine what level you should be exercising at. So we'll refer back to this a little bit later, but this is something that you should be aware of, and I think it'll be useful going forward. Yeah. So this is just an overview then. So when you're speaking with cardiologists or nurse, as I was saying, they may have given you restrictions around the top element, which is the moderate intensity exercise, and you may have been told to do low intensity exercise. But have you been? But the question to ask yourself is: have you been given restrictions on the other three elements, including balance and flexibility, minimizing sedentary time, or even strength training? Because a lot of people have. I've worked with people with cardiomyopathy patients, and working in phase 3. And working privately with these patients as well. And a lot of time they have been given restrictions around the aerobic exercise and told to work on a light intensity. And because they've been told to work on a light intensity, they've totally forgotten about exercise or forgotten about the overall benefit of exercise. So they've totally neglected strength training. They've totally neglected balance flexibility, which could include yoga, Pilates, and they've also minimize sedentary time because they feel like if they're not going out for a jog or going for a run, or if they're not involved in a gym in some aspect, then what's the point of doing activity? So the question here as well is just what restrictions have you been given? Under what element did those restrictions apply? Was it cardio? Was it balance flexibility? Was it strength? Were you told to sit down more? And if you weren't given restrictions in a particular area, could you go back and speak to your nurse or your cardiologist saying, you told me about restrictions in cardiovascular, but can I do strength training? Can I do Pilates? Can I do yoga? How about I just minimize sedentary time and keep it more active and on your feet as opposed to trying to hit a higher level of intensity? Because ultimately, these are the benefits of exercise, and all patients do benefit from this. You don't necessarily need to be hitting a moderate intensity or high intensity exercise to get these benefits. And that's the thing to be aware of as well. So I'll just give a moment just to kind of a look at that. So you have the cardiovascular, you have the oncology in relation to cancer, you have musculoskeletal in relation to osteoporosis, falls. You got your endocrine, which is your weight, managing diabetes, and you got neurological in relation to anxiety, depression. So sometimes as well, when patients are told to reduce their activity level, that can have a negative impact on the neurological side of things in relation to anxiety, depression can increase because you're taking away, in some cases, their form of identity. I've had a patient there recently who was, had a few patients, but normally there might be an avid runner, might be an avid kind of sports player. And when you tell them to do or stop a particular activity, you've taken away their identity because they've spent maybe the last 10, 20 years doing that. And now they're saying they can't do it anymore. So just because you may have a reduction on the exercise intensity, maybe looking at this weight side of things, the flexibility, the mobility, reducing sedentary time, because ultimately these are the benefits that you can still gain from being active. And with cardiomyopathy patients, these are also other areas that we like to be looking at as well, because when you're looking at the health of an individual, it's not just how active you are, it's also about your lifestyle behaviors in relation to drinking, smoking, dietary habits. So it's good to take that holistic review and kind of look at your lifestyle behaviors as a whole. It's slightly different. Cardiomyopathy is different to cardiovascular disease in relation to traditional cardiovascular disease is a development through not so great practices in your lifestyle. So for example, if some individuals are overweight, if there's a family history of heart disease in the family, if they're inactive, if they have high levels of smoking, alcohol, they can develop cardiovascular disease, which would result in a heart event, which may require a stent, a bypass, etc. But with cardiomyopathy patients, it's not necessarily a lifestyle-related disease. But what we don't want with cardiomyopathy patients is following diagnosis is where it can develop into a lifestyle disease, because they've been given restrictions in relation to not exercising, and then ultimately it can impact negatively on these other areas. Because why do we exercise, or why are we active? And this is a big component I see within cardiomyopathy patients. It's the psychological benefits to exercise. It might be improving your mood, helping to reduce stress, self-esteem, your pride in kind of your physical accomplishments. For some, it's even body image, or just increased feelings of energy. Personally, myself, I find if I do some form of exercise, I always feel more energetic and more optimistic after I do that compared to when I'm not exercising. And then just as a whole, then decreased symptoms associated with depression. So you got to ask yourself, why did you exercise? If there was a health benefit to it, was it just a health benefit? Was it just a health benefit, or was there more to it than just for the health benefits? Was it one of these areas here? And if it was one of these areas here, how do we get that same level of psychological benefit, but maybe with the new restrictions that you have? There's different forms of exercise as well. I'm not saying necessarily this is what I'm recommending you to do, but you have to think about as well is, if you've been given certain restrictions, could you alter the exercise you do? Could you change the type of activity you do? Would that be of benefit for your condition? So these are conversations that be worth having, as I was saying, with the health practitioner, be it the nurse or the cardiologist, or even your GP, or which they could potentially refer you on to a specialist to get these answers if you're no longer in contact with your cardiologist. This is another area as well, which is maybe not spoken about as enough, is steps. So in relation to steps, this can have a health benefit as well. So just because you're not hitting the intensity, i.e. you're not going for a run, or you're told not that, you're maybe restricted about going to moderate intensity exercise, but can you focus more on your volume? So the intensity is low. So steps is basically anything included from the moment you wake up till when you go to sleep. So getting up in the morning, kind of brushing your teeth, making breakfast, that all counts as your steps. Walking downstairs, walking out into the garden, going to see friends, that's all classing as steps. And research has shown that those individuals with higher step counts have more reduced cardiovascular disease. So when I talk about higher step counts, I don't necessarily mean 10,000 steps. So if you have an individual who's only doing 2,000 steps throughout the day, from the moment they wake up to the moment they go to sleep, an improvement for that individual will be attaining maybe 2,500, 3,000 steps. So what's your step count at the moment, and can you improve it slightly from where you are? It doesn't necessarily mean that you have to walk faster, that you have to push yourself to a higher level of activity. It just means that you're just being more conscious of your daily activities, and going back into the recommendations that we spoke about earlier, could you increase your physical activity? And this is what would encompass physical activity, where the intensity is low, intensity is light, and you're just talking about volume more than kind of hitting that certain intensity. So there's just different kind of research there that was shown. Whereas a woman here was asked This last one here, 32 women were asked to self-monitor their activity using a pedometer and increase their steps by at least 2,000 to 3,000 today, or sorry, 2,000 to 3,000 per day. And they found there was improvements in their lipid profiles, which basically means their cholesterol. So it doesn't mean that they were walking faster. It doesn't mean that they were running or anything like that. It just means that they were consuming a higher volume of steps. And it doesn't necessarily mean that you have to go for an hour walking either. When you're say if you're making a cup of tea, waiting for the kettle to boil, instead of standing in one spot, could you doing a little march while you're watching TV? If there's an ad break on, could you be standing up just to accumulate your steps that way? So there's different ways of accumulating steps without actually having to go outside, especially if the weather is not on your side. So how many steps per day? But this can be, as I said, it varies from person to person. But what I would say here is just what is your step count at the moment per day? And say if it's 4,000, 5,000, whatever it may be, could you look at manipulating that? And would that be, would your cardiologist or would your nurse be happy with you doing that, focusing more on your step count? But this is a discussion that you have with them, your practitioner, and they will create more awareness around this with you as well. And they'll say, yeah, that sounds good. I'm happy for you to do that. Or they might say, what the steps that you're doing at the moment, I think where you are is suffice, and I don't advise that you should increase it, whatever however the topic may go, but it's worth discussing with them. So these are just kind of different step categories. But as I said, if you're if you're only doing 2,000 steps per day, which is below the 5,000, and moving it to 3,000, there's benefits to be had at all these levels. So I'm not saying now that you need to go out and achieving 12.5 to 13,000 steps or 16,000 steps, not necessarily. So it's just something to be thinking about. In relation to kind of where you live as well, this is kind of the London Underground, but if these numbers here, say from, you can see here like Leicester Square, going from Leicester Square to Covent Garden, this 400 means basically 400 steps. So instead of taking the tube along this line, that you would just walk and you would accumulate 400 steps. So there's different ways or different things that you can do to think about how can you accumulate more steps in your day-to-day. Obviously, you may not live in the London area and this may not be relevant to you, but in your local area, if you have a certain routine, if you go to the shop or go shopping, could you be parking further away from the shopping center? Instead of parking at the door, could you park a little further back just to accumulate more steps? So just thinking about your current day-to-day. So if I go back a little bit, so these are the general recommendations, not for cardiomyopathy patients, but for the population as a whole, these are the UK recommendations: 30 minutes of moderate intensity, as well as strength training, as well as balanced flexibility, as well as minimizing sedentary time. So the next section is keeping that in mind. These are the questions I believe that you should be asking your cardiologist or you should be asking your nurse practitioner. What is that individual recommending? So I recommend that you do low intensity exercise, but what does that entail? What does that mean? You're putting a restriction on the amount of steps I should be accumulating per day? Does that mean you're putting a restriction on the intensity, i.e. keep it light intensity? You need to be a bit more, being more informative about your condition and being aware of the exercise elements. Hopefully you can ask more specific questions next time you're meeting these practitioners and then pin them down to get more advice that's applicable to you, especially, as we said earlier, especially if exercise was, for some patients, part of your identity, especially if it was something that you really enjoyed and it made you happy and you got immense enjoyment out of it. We don't want to necessarily remove that, or can we continue with the exercise, but how can we adapt it to suit your condition? Is there avoidance of certain activities? Is there saying, so say, for example, in relation to cycling, they might have, say, oh, cycling, I don't recommend that, but why? Or swimming, I don't recommend that, but why? So if they don't recommend swimming, can you recommend alternative activity? Is there avoidance of certain sports? So with cardiomyopathy patients, and it's not necessarily someone you're going to be diagnosed when you're 70 years old. You could get diagnosed at 20 years old. So are you talking about certain sports, like, for example, don't do soccer, don't do boxing, but there's other sports which are not the same intensity, for example, golf, cricket, bowling. Are you talking about sports in general? Or are you talking about more specific sports? And here is duration of activity. So are you saying you can't do moderate intensity? Are you saying I can't do it for an hour a day? Are you saying I can't do it for half an hour a day? What are you talking about in relation to duration? So if I do light intensity, is there a problem then of my duration per week? And also as well, when you get answers to these 4 questions, what are the reasons you're putting these limitations on me? Is it because you're worried about a progression of the condition? Or are you worried about worsening of symptoms? And if you are worried about a progression of condition or worsening of symptoms, what are the markers that you're looking at that will tell me that this is not abnormal? So, for example, if someone's recently diagnosed with ARVC, the restrictions for those patients can be a lot stricter than someone who's been diagnosed maybe 5 years ago. So if you were given restrictions to exercise and you were diagnosed a number of years ago, do those restrictions still apply? And looking at with cardiomyopathy patients as well, you can be going back in for 6 monthly or 12 monthly reviews. Has there been a progression of your condition or a worsening of your symptoms? And if there hasn't, do those same restrictions apply? Can they be a bit more lenient? Also as well, the cardiologist needs to take in the individual that's sitting in front of them. So I've had patients before where they're kind of in their 30s and they're kind of in their prime as such when it comes to exercise and fitness, and then they've been told that you can't say run anymore. But as I said earlier, that you're potentially taking away that person's identity and what that is the main portion of their life. So you have to take the patient's feelings in as well. And that's why it's a more open conversation that you'd have with patients and determining, okay, the exercises that you want to do, I don't necessarily agree with at the moment, but when we come back after a year or 2 years, and if there hasn't been a progression on your condition or worsening of symptoms, we might be more open to allowing that activity. So the key point in here is, in relation to an activity that you want to do, you speak to your cardiologist and say, I want to go, for example, say I want to go swimming. Instead of just saying, can I swim? Where they might say yes, no. You say, can I go swimming? I find this an easy activity. I find it easier than walking. I only want to do it for half an hour twice a week. And I've been doing swimming for quite a while. And I've never been out of breath. I've never found it challenging. So you have to give more information as well when you're asking these health practitioners about, can you do an activity? And if they say no to swimming, then these are the questions you're asking. Why can't I do it? What is your worry? And what other activity can I do instead? And the ultimate goal is down here at the point, we're hoping to adapt the exercise session and still gain benefits. So what is your condition and how can we adapt it to still gain the benefits from activity? Hopefully that makes a bit of sense. And these are some of the recommended or guidelines in relation to arrhythmogenic cardiomyopathy. So it would suggest that people participate in a low level of intensity of exercise up to 150 minutes. This can vary from person to person, so it would be worth getting your individual recommendation from your nurse practitioner or your cardiologist. If people want to engage in higher levels of activity, up to moderate intensity, it depends once again on your medical condition. And some of the factors that may be taken into consideration will be if an individual has no history of cardiac arrest or VA, which is a ventricular arrhythmias, no unexplained syncope, which is loss of consciousness, and no structural abnormalities, and premature ventricular contractions. I'm not expecting you to understand what any of this means. It's just going back to my previous slide. What is the cardiologist recommending and why are they recommending it? So is this an area that they're saying, I want you to do low level because of XYZ conditions that you presented with, and therefore I don't think you should do whatever it may be. So sometimes these health professionals may offer advice or guidance, but sometimes when they do that, there might be a kind of lack of certainty or lack of awareness on their behalf about exercise. So for example, if a practitioner is not a competent swimmer and say has a fear of swimming, and then you ask that individual, can I swim? There can be a bit of bias towards where if that practitioner is fearful or doesn't like swimming, they might put that across to you and say, no, I don't think swimming is good for you. It's really hard. So by questioning them, okay, you're saying I can't swim, but why are you saying I can't swim? And then you'll understand that maybe it's not their bias, it's more of a health concern, that the reason they're asking you not to swim, which will help you to adapt the exercise going forward, and it'll help you to have further confidence in what that practitioner is saying as well. So with the exercise restrictions that you may be given, you may be given very restrictive recommendations, but that doesn't mean that you still can't find a way to exercise. So this is a case study of a 27-year-old patient with ARVC. He was a very active individual, but on an occasion he was cycling up a hill and he started developing symptoms, i.e. breathlessness, which was abnormal for him because he's a very fit individual. Following further investigations and tests, it was found out he has ARVC. Following that, then, he was restricted by his cardiologist to 110 beats per minute, which basically means that if we go back to, if I go back all the way up here, 110 beats per minute for this individual is around here, a light intensity. So somewhat hard is where the breathing is increased, but he's not out of breath. So he was restricted to a light intensity. So that patient was referred to me on a one-to-one basis. So how do you work with someone who's been told that you can exercise, but you have to keep it at a light a light intensity? So we have to review these guidelines. So the top section here, 150 minutes of moderate intensity, I can't do that with him because it's moderate intensity will be above 110 beats per minute. So my aim is going to be to focus on balance and flexibility, minimizing sedentary time and strength training, and monitoring his heart rate. So in relation to the balance and flexibility and minimizing sedentary time, we just had conversations about his current activity and his current kind of day-to-day routine, and talked about different ways that we could move forward with that and make it more productive for him to get some health benefits on where he was at the moment. And with the strength training, with elements of cardio, we did a session where I monitored his heart rate throughout the whole session. So this was kind of this was the warm-up with the patient, which I'll explain a bit more in a moment, but this was his heart rate. So these kind of spikes here are just areas where we maybe challenge them a little bit more in relation to doing some lower body strength exercises. And when you do lower body strength exercises, they're bigger muscle groups and they involve the heart rate more, so your heart rate is going to go up further. So this was a 15-minute session I did with him, but as you can see, his heart rate stayed below the 110 threshold given by his cardiologist. It was the maximum we had here was 90 something, but this patient still found it beneficial. Is it as good or is it better than the hiking he was doing up the mountain or the cycling he was doing up the mountain? No, it's not meant to. The thing about this and the thing about adapting exercise, it's not meant to replace the activity you're doing. What it's meant to do is, you've been given exercise restrictions. How can you still be active moving forward with those restrictions? And that's the idea of working with someone like myself, working with the nurse, working with the cardiologist to see how you can still be active, but within the restrictions that you've been given. That's the idea of this talk. So ultimately, like, I've had patients where when they exercise or when they push themselves, they get this kind of feeling within themselves of kind of endorphins and things like that, and where they've kind of felt tired and pushed, and then they felt kind of this kind of a different level of satisfaction. So that is a difficult thing to replace. especially if you really enjoyed pushing yourself once you have a cardiomyopathy, once you have a health condition. But this is more to just reevaluating what's important to you. What was the reason you exercised for in the first place, and how can we still get those health benefits, but making the exercise session safe for you? And this I wanted to go back to, because when you do any exercise, and I'm sure the nurses or cardiologists would have had some discussion around this with you, but when you do exercise, it is important that you engage in some level of warm-up, in the sense that you just don't go from sedentary sitting down into some level of activity, that you kind of prepare the heart before the activity. What intensity you get to for the main part of the exercise will be individualized, and it's dependent on previous factors in relation to any past medical history and how your heart responds to exercise. So once someone like myself understands those and understands your medical history, we have a better opportunity to develop this activity for you. What should your warm-up be? What should the main phase consist of? And what should a cool down consist of? But by asking the questions, cardiologist or the nurse, hopefully you will gain knowledge to know how to structure your own exercise session without necessarily having to speak with a specialist like myself. So what opportunities are out there for individuals like yourself to get specialist input in relation to exercise or exercise advice? Phase 3 is where I work at the moment, and that's just basically a program that can vary in length from like maybe 6 to 8 weeks, and you're attending face-to-face classes once a week. Phase 1 is generally when you're in hospital. Phase 2 is when you're discharged home, and phase 3 is just an in-house, in the hospital or in the community, and it's with people like myself or with nurses, and you're in kind of a safe exercise environment. And after that period of time, you're discharged. It's a rehabilitation program. After that period of time, you're discharged, and you're entitled, you're maybe referred to in phase 4, which phase 4 is exercise in the community. And this is not with nurses or anything like that. This is just with appropriate qualified individuals, where they run exercise classes for cardiac patients, including cardiomyopathy patients. Separate to that, you can engage as well in GP referral. And GP referral is, or another thing is exercise on referral, which I'll discuss in a moment. And separate to that then is community groups. So for example, when we're talking about physical activity, increasing your steps, could you involve yourself in a group that is not necessarily physical activity orientated, but helps to get you out of the house, helps reduce your entry time? So for example, involving yourself in some gardening group, involving yourself in some pottery, involving yourself in some art group or painting group, involves you to commute to that particular venue, which will be to the car, public transport, etc., where you'll be on your feet. You'll be there for a period of time, and you have to commute back. So it's not particularly an exercise session, but it does involve you. It does involve physical activity. And also, there's also information on websites. BHF, the British Heart Foundation, the NHS also has information, and also Cardiomyopathy UK. So if I was to talk about some of those a bit more individualized now. So I'll go back to the ICDs in a moment, but this is phase 3. This is the areas we cover in relation to weight management, blood pressure management, diabetes management, cholesterol, smoking cessation. The thing about phase 3, though, unfortunately, it's more targeted towards people with traditional risk factors. So like I said earlier, people who've had stents, bypasses, or even a valve surgery, not necessarily cardiomyopathy patients. So not all cardiac rehab programs will accept cardiomyopathy patients. It's usually on an individualized basis. So sometimes you have to, if you get a referral to cardiac rehab, it might be an automatic referral. For example, I work in Imperial NHS, and if you're under a remit in relation to your GPs in the area, you'll automatically be referred to a hospital. If you're outside of that, for example, some places in the south of England, you may not be accepted onto cardiac rehab, and the only way to be accepted is to be referred by your heart failure nurse. Whether you're applicable to cardiac rehab or not, you could always speak to your GP, or you could always try locate where your local cardiac rehab facility is, which I'll show you a link in a moment of how to do that. Whether this will be beneficial to you whether it be beneficial to you or not will depend. But it's all, maybe it's more beneficial for patients following a recent diagnosis of cardiomyopathy. If you've been diagnosed, say, a year ago, then this sort of support maybe not be as beneficial to you because you've been through various support groups, you've been through various resources, and you kind of you're coming to terms with the condition now. But if you've been diagnosed recently, cardiac rehab can help you in that diagnosis and how to get back to your normal level of activity, should I say, or get back to a normal life. There is websites out there then where you would put in your GP, or where you put in your postcode location, and all these red dots will tell you where your local phase 3 is, i.e. your cardiac rehabilitation is, or where your local phase 4 is, which is basically kind of a long-term exercising program. Once again, phase 4 may or may not accept you onto their program. It depends from service to service. And the reason being is just cardiomyopathy is quite a still evolving condition, and there's not a whole lot of research or a lot of awareness around the condition. So therefore, some individuals don't feel confident in exercising people with cardiomyopathy, but it's more of a dependent on that individual organization where they'll accept you or not. This is the GP referral scheme. So this is just an example of everyone active. It's a chain of gyms, and you can get referred to that. And what they will do is they will design an exercise program for you. They'll have a meeting with you on a one-to-one basis. They'll design an exercise program for you, and you'll be carrying that out in the gym. And then they'll review at 6 weeks and again at 12 weeks. Generally, it's referred to that. There is a self-referral, or you can refer to the GP. In relation to conditions they accept, this is the conditions they accept. It's not just cardiovascular disease. So cardiomyopathy would kind of fall under cardiovascular disease. It can be other conditions that they accept as well. Once again, they may or may not accept you as a cardiomyopathy patient, but it's worth something, having an individualized discussion with your GP to get referred to such a program, and then discussing there whether you're appropriate or not. These are the kind of community groups that I was talking about. This is just in the Ealing area where I work. So these are not all exercise groups. They're just a list of community groups, volunteering, etc., that you could be involved in just as a way of physical activity, but it doesn't actually involve exercise where you're getting up to a certain intensity. This is also online resources from the British Heart Foundation. They have a lot of home-based exercise programs. Whether you should do the program or not will depend on what your individual diagnosis is and what restrictions you've been given. But seated program basically just means you're doing an exercise program from seated down, and level 5 is just a more dynamic, a higher level of exercise. The NHS also provide exercises in relation to aerobic, strength and flexibility, looking at balance, core exercises, etc. So in relation to the questions I referred to earlier about your cardiologist, the aim of this is just to challenge your cardiologist. So generally, following a cardiomyopathy diagnosis, a lot of people are given restrictions to this green area here and told about not doing activities above billiards, which is just bowling, cricket, curling, golf, riflery. It's just low intensity, low dynamic exercises. So if you've been restricted to here, the bottom left-hand corner, why are you restricted to there? If you've been restricted to there 2 years ago, do the same restrictions apply today? If you've been restricted following a recent diagnosis, what would determine you going to a higher level of activity? Because ultimately the research in relation to arrhythmogenic cardiomyopathy is evolving, and it's evolving year on year. So restrictions that you've been given today may not apply in a couple of years' time, or the restrictions that you were given 5 years ago may not really apply today. So it's worth having that continued conversation with the cardiologist or the nurse practitioner. This is just safety things, then just about general things which will apply to anyone, is not to exercise is just generally not eating after a heavy meal, where you're feeling unwell, kind of cold, fever, or kind of very hot or cold conditions, or if you're diabetic, make sure that's under control before you have any exercise. If you have unusually high heart rate, or if you've forgotten to take your medications. And these are some exercise considerations continued about when not to exercise, about tiredness, pain or discomfort in chest. But these things should be common sense, because when you're being active in your everyday activity, you will know or get to understand your body, and you will understand these more easily. Then if you feel a new symptom, you will be able to determine whether that's appropriate to exercise or not. So I'll go back to the conclusion in a moment. So I'm going to go back to ICDs. So generally, ICDs or pacemakers are devices that can be fitted following a cardiomyopathy diagnosis. The type of device fitted will depend on the individual. It can be a pacemaker, it can be an ICD, or which is fitted up towards the shoulder area. It can be a subcutaneous ICD, which is the SICD, which is fitted near the rib cages, or you can have a CRTD, or P, which is a cardio resynchronization therapy device with pacing, which is a combination of helping your ventricles to beat in synchronization as well as pacing, or helping your ventricles to beat in synchronization as well as having a defibrillator, which is a shock. I'm not going to go into detail about this, because ultimately, if you have one of these devices, you would have underwent the necessary information about these from your physiologist when you've gone for your checkup, and they would have told you about this. But the only reason I'm mentioning it now is because ultimately someone might be seeing this talk who is recently having one fitted or may have one fitted, because with cardiomyopathies as well, you sometimes when you're initially diagnosed, you may have one fitted at that point, or you may have one fitted at a later stage. So it's worth knowing about these. Can you exercise with these devices? It's not, generally with these devices, the device is not what limits you in relation to the exercise. It's your underlying condition that will limit you, because with these devices, they will monitor your heart rate for arrhythmias. Generally speaking, with in relation to the setting of a device, you might be given certain thresholds, which I don't expect you to understand now, but you might be given certain thresholds that you shouldn't exercise above. And those thresholds are generally higher than what would be recommended for the condition. So ultimately, if you have an ICD, that's not going to be the limitation for your exercise. The limitation for your exercise will be your heart condition, if you have arrhythmogenic cardiomyopathy. But if you have had an ICD, and if you do have one fitted, generally you will get this advice from your physiologist, but generally for the first 6 weeks, you're trying to limit your range of motion to a below shoulder height. That is just to help with the leads settle. If you have a subcutaneous ICD, which goes under the ribs area, there's less limitations than one that's fitted up to near the shoulder. And generally with this as well, there might be restrictions, like about diving, about kind of immersing yourself in kind of like scuba diving, etc. But generally, the cardiomyopathy will limit you more than the ICD in relation to engaging in certain activities. So if you do have an ICD or worried about, I won't be able to do this, that, or the other with an ICD, it'd be probably your underlying condition that will limit you more than the ICD. But generally, your health practitioner will be able to give you a lot more advice around that and the different types of devices as well. So we're coming towards the end anyway. So I just want to go on to the conclusion as well here. So looking at the 4 areas of recommendations that are for the general public, which is exercise, where individuals are recommended to attain 30 minutes of moderate intensity as a general recommendation. If you've been told to restrict around that, what level can you attain for how long? Or questions to ask your cardiologist. In relation to strength training, can you do that? How many sets, how many reps? Basically, how much of a weight can you lift? How many times? How heavy? In relation to steps or physical activity, can you do as many steps as you like? Is there a restriction to that? And also balance and flexibility. Maybe can you do activities that are more focused on that, such as yoga, Pilates, which ultimately is good for individuals, especially as we get older, to help reduce falls, and also to help reduce like certain elements in relation to back pain by improving core strength and posture. So what activities can you do? How can we adapt it? what are the updated guidelines in relation to your condition? So if you've been given restrictions a couple of years ago, do those same restrictions apply today? If you've been given restrictions recently, will those same restrictions apply in a year or two? Maybe, maybe not. And if you've been given restrictions, have you been given restrictions? What markers do you possess that they've told you to restrict certain activities? And we talked about safe structuring of exercise, i.e. about kind of warm up and cooling down. We talked about exercise opportunities, which is phase 3, which is the kind of part of the NHS rehabilitation program. Phase 4, which is separate to the NHS, which is run in like local communities. We talked about GP referral schemes. We talked about NHS opportunities in relation to kind of exercises that are available there, or the British Heart Foundation. And finally, just challenging your cardiologist to ultimately get back to what you enjoy doing and knowing when to stop exercising. So I kind of went through that quite quickly in about 40 minutes, which I'm quite happy about, because normally it's been taking much longer, up to an hour. And has there any questions there?
Phase 4 cardiac rehabilitation, what qualifications should the instructor have, and should I be asking them? And then should they be a member of the BACPR? Yeah,
so you don't need to ask them what qualifications they have. The reason being, if they're running a phase 4 program, they have the basic qualifications already. They're not allowed to run a phase 4 program without having those qualifications, which is part of the BACPR, which is the British Association of Cardiac Prevention and Rehabilitation, which is basically just a governing body that provides qualifications and courses for individuals wishing to work with cardiomyopathy patients or wishing to work with patients with cardiovascular disease, equipping them with the necessary qualification and experience to be able to run such programs. So if it's a phase 4 as a standard, they should have that. Otherwise, they shouldn't be advertising it as a phase 4 program. But you can have a conversation with them. But the only limitation I unfortunately with that is with phase 4, like phase 3, it's more geared around traditional cardiovascular disease. So with phase 4, you need to say to them, I have XYZ cardiomyopathy. It might be ARVC, it might be hypertrophic cardiomyopathy, it might be another one. I have this condition. Can I join this program? And then it's up to that individual for them to say yes or no. Obviously, you would need a referral, which all patients do, but it also depends on your location. For example, from personal experience, if you're in the London area, there's a lot more knowledge about cardiomyopathies than if you're outside of the London area, which is unfortunate. So it's not to say that all phase 4 programs know about cardiomyopathies. It's on an individualized basis. But if that individual is not happy with your condition or doesn't feel knowledgeable about the condition, they should have the professional integrity to say, we don't accept this patient for whatever reason, and unfortunately I can't assist.